Okay, fine. So now let's look at this case number 10. I'm going to wait for that to download. And this was someone who came in with abdominal pain. And it looks like we're probably looking at a porta venous image, aren't we? Most likely. Yeah, so I'm just waiting for that red line to come across. I guess I can just sort of start scrolling from the top. So it looks like a contrast enhanced study. Let me know what you think of this CT scan once it loads up for you. So for those that don't know, we are on case. Oh, so someone's raised a hand. Is that because you've got a question? Someone raised a hand because they've got a question. If you've got a question, yeah, go for it. If not, that's fine. I'm going to carry on. I'll let Danish see if you've got any questions. So, okay, let's scroll through this CT scan. We'll go from the very, very top all the way down, all the way down, all the way down. So this looks like it's a porta venous image coming all the way down. Oh, someone's talking? No. Okay, so what have we seen so far? Yeah, so someone's saying, yeah, good, good. So then what if it, yeah, so if someone's coming with abdominal pain, we've got to start thinking along the lines of what could this be? So let's scroll through, let's scroll through. What can happen with that abnormality that you're talking about? So one of the challenges I've always found when it comes to what we're looking at here, so someone's already pointed out, I'm just going to go for it because the rest of it is not quite uploading just yet. But as you kind of come to the top of the image, some people may not spot straight away that this aorta does not look normal at all, right? So if we see here, if you keep your eyes down there, scroll down, you can actually see there's like a linear density, like a linear difference between this area and this area over here. And so as you scroll down further, you can see that this kind of curves around this way, keeps going, curves around that way, curves around that way. And then it sort of communicates with that area there. And then that communicates that way. This communicates that way. And there's almost like two different lumens that are communicating with different parts, with different parts of the body, right? And so, yeah, everyone's right. There is an aortic dissection. So the next challenge is trying to think about what is the true lumen and what is the false lumen. So generally speaking, not a hard, fast rule per se, but the one that's slightly more dense is usually going to be the true lumen, because that's where you get the least resistance when it comes to flow. And the one that's got more resistance is going to be the false lumen. So that is, I don't know, if you look at the blood vessel like this, you got your blood vessel wall, you got your blood flowing through, and then sometimes a weakness here can result in a sort of like a different pathway for the blood to go. So instead of going down the normal lumen like so, it ends up going along the wall and stripping it and stripping it and stripping it. And you can imagine that that's not going to be the easiest way to go, right? You'd rather go down the normal lumen, but what ends up happening is gets stuck down there and keeps going through into the, and it may actually start dissecting further and further. It's dangerous because obviously it can result in a cascade reaction, can result in ischemia, obviously very painful because essentially aorta is ripping from the inside of you, which is a horrendous appearance, horrendous thing to think of. And also what ends up happening is that you get this sort of what can be like little cobweb appearances, right? Little tiny cobweb appearances, because that's kind of clot trying to form. And actually, usually you find that the one that's kind of more circular and less crescenteric is more likely to be the aortic dissection. So the thing to worry about is when you've got sort of false lumen communicating with the large vessels, because then you've got to start worrying whether, you know, true blood is going to get all the way through to the rest of the organs. And actually in this particular situation, we can see that the kidneys are actually enhancing pretty normally, and the bowel doesn't look too bad either. So if we go back, very, very important to make sure that you don't have underlying ischemic bowel, because if you've got dissection, you can get thrombosis. Thrombosis can result in lack of blood flow getting into the bowel, and the bowel can die, and et cetera, and it becomes a big cascade of problems. Aortic problem leads to blood flow problem, which then leads to blood supply problem, which then leads to ischemia, perforations, and all that stuff as well. So what I always do as well, just to be 100% sure, is have a good look at the bowel. I follow all the way around. You can see my mouse is, we're going all the way here. So these are the constants. I always say the descending colon is a constant, come all the way across to the transverse colon, all the way across, and actually the bowel looks okay so far. Coming down to this area over here where the cecal pole, everything looks okay. And then I keep a sort of cursory eye down the middle of the abdomen just to make sure the small bowel doesn't look particularly inflamed either. So I know that part of the body is missing there. And then bonus points, I guess, not particularly important, I get, with this particular patient. They do have a periumbilical hernia, and they've got inguinal hernias located in both over here, right, as well. Can you see that? So the little inguinal hernia on the left, which contains some fat. Generalized subcutaneous edema as well, which is pretty much unrelated to the overall picture of the patient. So yeah, exactly right. We've got a patient who's got aortic dissection. Now you can imagine that someone like this turns up with abdominal pain, and you may miss that. And the reason why you may miss that is because this is not a dedicated. Yeah, usually the false lumen would be smaller. Actually, there's a really good checklist. I won't be able to find the checklist right now, but if you type in aortic dissection checklist, there's like literally a really good checklist looking for how you can tell the difference between a true lumen and a false lumen. In reality, if you're reporting, right, especially if you're a registrar or anything like that, the biggest thing you just got to say is what type of dissection it is. Look for secondary findings. Is it ischemia? Is there thrombosis? And all that kind of stuff. Vascular referral done. Yeah, and then they would end up talking to the vascular surgeons, the interventional radiologists, and all that kind of thing. So I think you can actually keep it fairly simple when you're a general radiologist reporting something like this. The reason I brought this up is because at first glance, you think abdo-pelvis. And if you don't have the vessels as your check area, you may walk away thinking, yeah, abdo-pelvis normal, no abnormalities, no perforation, no ischemia, et cetera. But that just being able to just sort of have a look at the aorta, or even doing the thing where it's also doing the thing where you actually have a look at the aorta to try and decide what phase of imaging that you're at. That can also help you. The other thing that can help sometimes is you get atherosclerosis with the aorta. So sometimes the atherosclerosis will kind of be pulled inwards. And so you'll see this sort of calcification linear bit. And then on the outside of that, you see some contrast. So therefore you'll be able to say that, okay, anything sort of inner to that calcific sort of density on the outside is going to be normal lumen. And anything outside of that is going to be false lumen. That's another way to try and identify which one is which. So those are some pretty decent signs to look for when you're doing that.